So a very good morning, very good evening. It's indeed an honor and privilege to be talking about lacrimal procedures in the very first AIOS midterm conference. Thank you for the opportunity. So coming from external to intranasal view, let's talk about endoscopic lacrimal procedures. Why I've used this graphic is akin to the quintessential magnifying glass in the hands of a clever sleuth. The endoscope acts like a magnifier to reveal hidden anomalies and hidden mysteries of the lacrimal apparatus. Let's see how. Coming to the diagnostic aspect, now it's become a routine to perform an endonasal evaluation before planning any kind of lacrimal procedures to reveal any abnormal anatomy or intranasal pathology which cannot be picked up with an external examination. Like in this adjoining picture, we see a septal spur. Similarly, during the recent mucormycosis crisis that our country faced, in a standalone eye hospital like mine, the only solution we could give was referring the patient to a multi-specialty setup. But a view with the endoscope gave us sometimes the first clue in the diagnosis of mucormycosis, where the patients were sometimes RT-PCR negative with very minimal symptoms. So this was what was shown was the typical feathery appearance. Just taking a swab and mounting it on a KOH mount revealed the fungus. And in that way, our endoscopic view was the only clue that suggested, that made us diagnose that this might be a case of mucormycosis and refer the patient appropriately. Coming to the lacrimal procedures, now literature is flooded with evidence about how the intranasal view gives an edge over routine probing, especially in cases where a buried probe is there, where there's a intranasal cyst, where a good and proper management can only be done with the clear view of the intranasal anatomy and visualizing the probe inside the nose. Also, the possibility of doing DCR in patients with recurrent acute dacrocystitis, interposing a conjunctival bypass tube and seeing whether it's appropriately placed, and also correcting concurrent septal deviation is only possible with the help of an intranasal view with the endoscopic DCRs. Now, a routine probing now is recordable so that it acts like a document and a proof, not just for ourselves, but for the patient. Like we see, now we get CDs in any laparoscopic procedures. We can think about providing CDs to our probing and DCR patients now that we have the choice of recording it. Also, the intubation is safer, quicker, and less traumatic. Citing an example, this was a 9-month-old baby who was having recurrent infections and the swelling in the medial canthus. What we imagined it as a routine probing turned out to be something different. So this is the routine probing that we are doing. After having probed the sac comfortably, we felt a soft stop when the probing was complete. So that's where the importance of viewing the probe inside the infusometer comes in. Now what we saw was, so this was a hump where our probe was going, and the light was reflecting off the cystic, of the wall of the cyst. So this was an intranasal cyst. Now we passed our probe past this cyst and then marsupialized it with the help of a crescent blade. So just piercing it wasn't enough. It's never enough. We have to marsupialize the cyst to prevent recurrence. And this, we are using a crescent blade to make a cruciate incision and marsupialize the cyst. And then the duct was patent. This is a gush of fluid. Coming to a routine endoscopic DCR, contrary to popular belief, we are away from angular vein and there's no possibility of hitting the angular vein when we are going from the nasal route. So bleeding is in fact, the chances of bleeding are in fact much less in endonasal DCRs. So this is how we lift the nasal mucosa, punch out the bone, confirm the sac with gentle pressure, then tent it with a probe and make our incision vertically, open it up like a door, and after mucosa to mucosa apposition, we can either leave it like that or put a tube. So this is the mucosa to mucosa apposition, and I'm intubating this patient. Let's come to the next indication, where sometimes we come across with flimsy or early common canalicular obstructions after DCRs. Those can still be salvaged by interposing a bicanalicular stent, and that is possible very easily with the endoscopic view. So this was a post-DCR patient who was having common canalicular narrowing, and we stented this patient, and it worked out successfully. Let's see some complicated case scenarios. Now, this was a dog bite patient with a severely scarred medial canthus. There was no question of being able to establish any patency in the existing lacrimal system. The only option left to us was a bypass tube. We chose a silicone bypass tube, which was cheaper. And although it was functioning very well, it was patent on every follow-up. The patient always complained about irritation and forearm body sensation, and then was lost to follow-up for another 7 to 8 years, only to return with IOPs in the range of 40 millimeter Hg, because he was constantly putting steroid eye drops for his foreign body sensation. So we convinced the patient to go for a replacement. Since the ostium was already formed, the bypass tube was already in place, all we needed to do was pass a metallic probe. I think this is not playing well. Let's come to the next slide. Pass a metallic probe inside the existing ostium and slide over our borosilicate tube upon it. And this is the post-op picture after 1 month, where it's snugly placed and patent. And this is the dye disappearance test of the same patient. Similarly, this patient had recurrent tube erosions. We didn't have access to endoscopic console at that time, and we were wondering why every time her Jones tube is getting extruded. Finally, when I was confident in endoscopic procedures, I discovered that my tube was wrongly placed. It was hitting the septum, and that's why it was getting extruded. Now, with the help of endoscope, we did perform an external procedure, but we confirmed the position of the tube endoscopically, and this is how the patient did after 1 month of follow-up, where the tube is snugly placed, and the fluorescent dye disappearance test is patent. Here's the tube.
Can you?
Yes. Just one more indication is again a scarred medial canthus, where the bypass tube was lost on follow-up. We did an Z-shaped incision for correcting the canthus scar, placed the tube, but after 1 week of follow-up, this is the first procedure, but after 1 week of follow-up, the tube wasn't found. But just one glance with the endoscope helped us in retrieving the tube and replacing it with the proper sized one. So this is how we retrieved it back and replaced it with a proper sized tube. And this is the video at final follow-up of 1 week, where the tube is snugly placed. This is how the patient looks now. I've made it a routine to confirm my distal kind of cut end of canaliculus endoscopically after seeing the annular fibers. I also pass the probe and through it and look for the probe in the inferior meatus just to confirm whether the distal end, which was appearing on the micro, is actually the distal end. Let's skip to the final slide, where post-operative, we can assess our post-operative findings by
sound check. Can we conclude, ma'am?
Yes, this is the post-operative findings, where we see a closed ostium and ostium which is about to be closed, and this was the one which was patent and it's not working. What an irony. So I would like to conclude this talk by saying that endoscope is an indispensable tool for lacrimal procedure.